Diagnostics is undervalued in global health. A lot of the diseases for which we need to diagnose patients and put them on the right treatment, we do not have good quality diagnostics. Take the example of HIV. WHO and UNAIDS has just in July of this year launched new targets for 2020. They are called the 90-90-90 targets, to have 90% of the people know their HIV status, to have 90% of those who are eligible for treatment to be put on treatment, and for 90% of the people who are on treatment for HIV to be virally suppressed. Now, for all those targets, to know where we are with regard to those targets and to indeed know that we have achieved them, we need diagnostics. And yet, we do know that a lot of countries don't have access to diagnostics that are outside of big urban centers. And so the global partners, including WHO, UNITAID, UNAIDS, the NGOs such as the Clinton Health Access Initiative, MSF, we're all working together to try and help companies with developing the right tests, evaluate them in a timely manner, and get them into use as soon as possible. And also, once they're in use in countries, to make sure that quality of the diagnostics and the quality of the testing is in fact good, so that we know that the results will be accurate and the patients will be put on the right treatment. So for HIV, this is ongoing right now, and there are funds involved. But for other diseases, maybe neglected tropical diseases, which 7 tropical diseases are targeted towards elimination, we don't have such tools. Now, a global emergency right now is the Ebola crisis in West Africa. And again, because it's not diagnostics for Ebola, diagnosis of Ebola infection is not a commercially viable market, there hasn't been any commercial development of diagnostics for detecting infection in the bloodstream of people who have fever. And so right now there are many funders who are putting together funding towards developing and validating new diagnostics for Ebola that is easier to do than a complicated lab procedure using molecular testing, or maybe using saliva as a possible non-invasive means of diagnosing infection instead of having to take blood, which also expose the healthcare workers to more risk than it's necessary. So this is going on right now, but normally the development of a new test from the inception of identifying a diagnostic marker to the end goal of having a product that could be used in developing countries is something between 10 to 15 years. And so we can't wait for that long with the Ebola diagnostics. So everyone is working very hard to try and accelerate the development, the evaluation, and being able to field test it in West Africa as soon as possible. And we're putting very short timelines for those. And hopefully we will achieve them so that we could identify quickly who is infected, put them into isolation in these treatment centers in West Africa, and then be able to make sure that they don't remain in the community and keep on infecting others in the community. So it's really the new diagnostics for Ebola are needed to screen Ebola cases, to better manage the patients that we have, as well as to identify those who would need to make sure that there's no transmission within the community to be able to isolate them if they're shedding virus. I think another global priority are the hepatitis viruses. For hepatitis B and C, previously there are tests using antibody detection to first know whether a person has been infected. And then once a person is seropositive, then you identify whether they're still shedding virus or whether they've become a chronic case or whether they're an active acute infection. Those diagnostics have been traditionally lab-based, which means that many patients actually have to go to a lab to be able to access those services. And quite often, then they have to come back to get their test results. And we know that if you have to travel a long ways to get to a lab, patients don't always come back to get their test results. So we know many results are actually wasted because people don't come back. And then there's very little chance of tracking to know who they are, to find them, and to be able to put them onto the appropriate care. So with this priority that we need to make sure that patients are identified, there had been a lot of impetus to fund the development of rapid tests for hepatitis B and C, to know that we could use them in outreach populations for drug users, for people who may be transmitting in maternal wards to infants, etc. I'm glad to say that with this funding, we've now have a whole lot of rapid tests that are very good. Compared to laboratory assays, they have sensitivity and specificities in their high 90s. And so I think for a test that can be done very quickly in the field, we know that we have to compromise a little bit in terms of the performance, in terms of being able to provide access to many people. And so I think that many countries are now recommending the use of these rapid tests for screening, especially as outreach to populations that may be marginalized from healthcare or at-risk populations that don't normally come into a healthcare service. Routine healthcare service. And so we are in gradually working towards more and more of these quality assured rapid tests that can be used for all the bloodborne infections. But we need to make sure, as we increase access to many, many places outside of laboratories, how do we assure ourselves that the quality of the tests remain as good as they are in the lab, as well as the quality of the testing is actually assured, given that they will be done not by trained laboratory workers, but by healthcare, frontline healthcare workers who may be very busy with a lot of other tasks. So that is one challenge that we are facing today, the quality assurance mechanism of these very accessible, simpler to use, and more affordable tests for bloodborne infections.